Hello and welcome to World Ovarian Cancer Awareness Day live panel discussion supported by AstraZeneca and organized by Voice of Healthcare. So, the topic of today's discussion is ovarian cancer, how timely diagnosis and treatment can save lives. To deliberate more on the same, we have some esteemed set of panelists here with us today. Let me start by introducing Dr. Niti Raizada, who is the Director of Medical Oncology and Hemato-Oncology at Fortis Hospital, Bangalore. Welcome, ma'am. I welcome Dr. Anju Singh, who is the Assistant Professor at Department of Gynecology at 𝐴IMS, New Delhi. Welcome, ma'am. I welcome Dr. Nidhi Tandon, who is the Consultant Medical Oncologist at Mazumdar Shaw Medical Center, Narayan Harudale. Welcome, ma'am.
Thank you.
We also have Dr. Rupinder Sekhon, who is the Senior Consultant and Chief Gynaecologic Oncology at Rajiv Gandhi Cancer Institute and Research Center, Vice President of Association Gynae Oncologists of India, and Chairperson of Oncology Committee of Association of Gynae Oncologists of Delhi. She'll be there with us shortly. We also have Dr. Shyam Agrawal, who would be giving the session chair address today. He is the chairman and director of Department of Oncology at Sir Gangaram Hospital, New Delhi. Welcome, sir. This session would be moderated by Dr. Nidhi Tandon. So I request Dr. Shyam to please give his session chair address and hand it over to Dr. Nidhi Tandon. Thank you.
So, good morning to everyone, and thanks for this invitation. I really applaud the Voice of Healthcare for organizing this broadcast on the World Ovarian Cancer Day, and I can really see senior people joining the broadcast here. So, I welcome you all. And it is very interesting also to see that for public health awareness, we have a research scientist joining in the panel, indicating the entry of basic research, which people must know these days for a variety of cancers, including ovarian cancer. So I think the incidence of ovarian cancer is increasing over the last several decades. And in India, nearly 50,000 new cases are diagnosed each year. The problem which we really need to understand about ovarian cancer is the late diagnosis. So, abdomen is a black box, as we all say, and people have a variety of symptoms which are not sort of specific to ovarian cancer. And that is a very, very critical reason for delay in the diagnosis. And if the patient is diagnosed in late stages, the outcomes are not that good. I think that is one very, very critical and important message needs to go to all the gynecologists and all the people at large. Ovarian cancer is not one disease. In younger age groups, it's a different disease process. You have the germ cell tumors, but in the middle-aged and elderly people, it has a different spectrum of disease, and they present differently. So we really need to highlight these issues when we do the panel discussion. So I think if we can just, and of course, as I said, the research angle which has emerged now in the last 2 to 3 years is the understanding of HRD. So I think there are several more issues which I'm sure which would be addressed during the panel discussion, which is being led by the medical oncologist from Bangalore, Dr. Nidhi Tandon. So I think hand it over to Dr. Nidhi for the further deliberations on the awareness program focused on ovarian cancer. So over to you, Nidhi, and thanks for the opportunity.
Thank you, Dr. Agrawal. We also have Dr. Suruchi Agrawal joined us. She is the Senior Scientist of Oncology at MedGenome. Welcome, ma'am. I now
Thank
hand
you.
over the session for Dr. Nidhi Tandon to lead. Over to you, ma'am.
Thank you very much, Shyam sir, for the introduction. And you basically brought about the main points which we need to discuss today. And that being, though ovarian cancer is on an increasing trend in prevalence, but still we see that most of the patients are diagnosed in advanced cases, and we are still not able to increase the life expectancy of these patients because of the late diagnosis. Now we have all seen as medical oncologists that the age group with which the patients are presenting is also going to the younger side, which is alarming, and where lies more importance in increasing the lifespan of these patients. So I would like to start my with Dr. Niti Raizada. Dr. Niti, in your experience, what are the common signs and symptoms with which the patients with ovarian cancer present?
Thanks so much, Nidhi, for having me in the discussion today. Thanks, Voice of Health. A very good morning to everybody. Well, ovarian cancer, as we all discussed, is a very important cancer because when it is diagnosed early, it's treated well. And with newer drugs, it has extremely good results. And we have to understand this is the third most common cancer in our country. First being breast, followed by cervix. This is the second most common gynecological cancer in our country. And unfortunately, when you ask about how it is diagnosed, most of the patients come in advanced stage because the symptoms of this cancer are really very mild and not very remarkable. Most of the women will come with abdominal distension. They might be worked up elsewhere for ascites, which was later out found to be malignant ascites. There would be features of early satiety. A rarer presentation would be acute presentation when the patients come with sudden severe abdominal pain, when they were diagnosed with ovarian torsion or intestinal obstruction. So that is another set of presentation. And the third group of presentation is when they were actually accidentally diagnosed. They are being worked up for fertility issues or just a routine pelvic scan, which finds out a complex ovarian mass or complex adnexal mass. And then we did a CA-125, which was high. And then we did another scan, like either an MRI or a CT scan, which showed that they are characteristics of malignancy. Now, signs, when they come to us, well, we definitely want to do a definitive scan to give us more localizing features. We also look for whether there is ascites or there's pleural effusion, which could be a part of it. And then we try to take samples of this, either peritoneal sampling or ascitic fluid sampling, which represents malignancy.
As Dr. Niti rightly mentioned, and we also discussed that the problem with ovarian cancer is that most of these patients present in very late stages, and most of these symptoms are very non-specific, which could have been because of variety of general causes. But uh, there are certain alarming features, in which case you need to go to your gynecologist or your physician at the earliest, and you should not waste time. And Dr. Anju Singh, can you please point out those symptoms in which the patient should not waste time and go to the doctor as soon as possible?
Thank you, Dr. Nidhi, for the question, and I would like to thank organizer. So, as Niti ma'am has already described the signs, like the ovarian cancer present with a very vague symptom. There are certain signs like if there is sudden abdominal distension, or there are weight history of weight loss and anorexia, and particularly one if patient is having the family history of any cancers. So these are the some of the alarming signs which patient should not miss, and go to the gynecologist. And sometimes the some cancers like granulosa cell tumors and all, they can present with the feature of abnormal uterine bleeding also. So we should not ignore the symptoms and go to the gynecologist for further evaluation.
Yes. So, thank you, Dr. Anju. And Dr. Niti, we are all discussing that it is usually diagnosed in the advanced stages. For other gynecological cancers like cervical cancer, we have the facility of a pap smear or a visual inspection with acetic acid available to diagnose the cancer at an early stage. Do we have any such screening modality which will help us detect asymptomatic patients with ovarian cancer?
So, Nidhi, as we all know, I mean, a screening is done for any cancer, which is widely prevalent in the community, and in which a very simple screening method can diagnose an issue. But when you discuss about the data and statistics of ovarian cancer, I mean, a universal screening program is not available, only in high risk cases. So, we have to identify patients who are high risk. So, when we talk about high risk cases, the most common thing we should see is that what Anju also mentioned is family history. So there are about 15 to 20% of the patient who will have family history of of cancer. It could be a uterine cancer, it could be breast cancer, colon cancer, or anything which points to high incidence of malignancy in the family. For such patients, we advocate either a blood test, that is a serum CA-125, and along with it, we advise transvaginal ultrasound. There are also certain other risk factors like even endometriosis or a person who has been on perimenopausal hormone or even patients who are for infertility treatment. For all those patients also sometimes a high risk screening is recommended.
Okay. One more question to you, Dr. Niti, is that if a patient is suspected to have ovarian cancer, how will you work up that patient?
So, Nidhi, firstly, I mean, do a good clinical examination, which includes a neck examination, a chest examination, and an abdo examination. Pelvic examination may show a pelvic mass. So, routinely, they would possibly already come with an ultrasound of the abdomen, which shows a complex ovarian cyst. We would like to do a CT scan to characterize the lesion or a pelvic MRI to characterize the lesion well, whether it's a complex mass or it's a simple mass with solid cystic areas. Along with that, we do a tumor marker known as a CA-125. If there's any ascites or there's any pleural effusion, we try to take sample of that. So it's known as cytology along with cell blocks to see whether they are malignant cells, and then we can characterize those malignant cell as a subtype of cancer, whether it's serous type or endometrioid type. Sometimes they would present with omental and peritoneal deposits. So we try to do a guided biopsy on that to take a peritoneal biopsy sample or omental biopsy sample and do histopathology and immunohistochemistry on that. Per se, an ovarian lesion is not biopsied unless it is metastatic. So if there's only an ovarian lesion, then they'll have to do a lab or an open lesion biopsy. It's known as a diagnostic lab. When the diagnostic lab, we try to do frozen section and check at the same time whether it is malignant or it is benign. And if it is malignant, we complete the staging procedure at the same time or the same sitting.
Thank you very much, Dr. Niti. That was a very detailed explanation of what will the patient go through if such a case is suspected. My next question is to Dr. Suruchi. Uh, Dr. Suruchi, Dr. Niti also mentioned, Dr. Sham also mentioned, and that a lot of ovarian cancers are being diagnosed at a much younger age group. A part of it may be responsible for our lifestyle habits, increasing obesity, or the use of infertility treatments. But we do tend to understand that many of these could be hereditary or as well. So, which are the patients with ovarian cancer in which you would suspect the cancer to be familial? And which are the patients who should be screened for the possibility of ovarian cancer considering their strong family history?
Right. So a very good morning and thank you for the organizers to invite me here to the forum. This is a good opportunity. And as Dr. Neeti and Dr. Shan has already mentioned that there is a family history that is associated with presentation of ovarian cancer. So in about 1/5 of patients, about 20% of patients may have an inherited factor that can be passed from generation to generation, and these patients can not only be presented with ovarian cancer, there can be multiple, I mean, family history of multiple cancers like breast, colon, and pancreatic, colorectal cancers. So the family history is one point, as has been already discussed, that if family history, there is a family history of cancers, then the patient should be tested for, I mean, genetic testing is recommended in that. And another point is, like, as you mentioned, the presentation of disease at young age. So that is also another point, that if patient is presenting the disease at young age, irrespective of whether the according to NCCN guidelines, irrespective of whether the family history is present or not, genetic testing is recommended to understand the risk associated with the genetic risk associated with the presentation of the disease.
Thank you, Dr. Suruchi. So I think what Dr. Suruchi wanted to convey with us all, that with newer targeted therapies available, we do want to screen all the patients for the possibility of genetic risk factors, irrespective of their family history or not. But a patient would be considered to have a hereditary ovarian cancer, or the family needs to be screened for the presence of a hereditary ovarian cancer if there are three or more close family members with uh, breast or ovarian cancer, if there are relatives with breast cancer in both the breast, or breast and ovarian cancer in one person, if there are male relatives with breast cancers, and as Dr. Suruchi rightly mentioned, other cancers like colon, prostate, pancreas, which are also present in the family. So these are the group of patients in which we would like to screen for the family history. Uh, Sir, you were mentioning earlier in your introduction about ovarian cancer being diagnosed in late stages. Can you put more light on it? Like, what are the causes and how can we prevent that?
I think as regards the causes of ovarian cancer, I don't think there is any clarity at this point in time. So we just have perhaps certain predisposing factors. You know, for example, women who are uh, obese, or who have a consumption of alcohol and maybe tobacco. But I think, as is being highlighted, the family history is, I think, the most important predisposing factor in the development of ovarian cancer. So any women who has a first degree relative, or at least two second degree relatives with cancers, including breast cancer, ovarian cancer, pancreatic cancer, prostate cancer. So I think those are the very, very high risk women who we need to do uh, the HRR gene testing in the index case, so as to identify women at high risk of developing breast and ovarian cancer. So I think the etiology or the cause is really, really unclear. Although, as I said, the numbers are increasing each year, and there are projections that the more than 50,000 women will develop ovarian cancer. So I think lifestyle changes are important for all women, because this is a public health program. So I think one needs to keep fit and do regular exercises to avoid obesity, and have the dietary control, so as to include vegetables and fruits in the diet. And I think these days work from home and from various computer centers, people do sit for long hours. So I think one really needs to have a balanced diet and a balanced lifestyle, so as to avoid the development of ovarian cancer.
Thank you, sir. Um, Dr. Rupinder, can you tell us a guideline of treatment so as to let the listeners come to know about what is the path we follow once cancer is diagnosed and staged as told by Dr. Niti. Hello, is Dr. Rupinder there? I think we have lost Dr. Rupinder. Can Dr. Anju please take this question about how we plan to treat a patient once the patient is diagnosed and staged for ovarian cancer?
So, like after a detailed history and examination, and once the diagnosis has made based on the tumor markers, like for there are certain tumor markers we get in these patients, like CA125, CA199, and CA, which are the markers of epithelial ovarian cancer, then we further evaluate the patient by further imaging, like CT scan or MRI, to know the stage of the disease. And after the appropriate pre-operative evaluation, we pose the patient for the surgery, which is the staging laparotomy for the patient. And in this staging laparotomy, we open the abdomen and we see the where all diseases. If there is ascites, then we have to send that, and if no ascites, then we take the peritoneal fluid washings, and after the appropriate staging, we do the surgery, which includes if patient has completed the family, then hysterectomy, bilateral salpingo-oophorectomy, and lymphadenectomy. And then based on the final histopathology report, we give the adjuvant therapy, which includes chemotherapy. And sometime when patients present with very advanced stage, then we can directly go for the neoadjuvant chemotherapy, and after that we plan the patient for surgery. And one more important thing in management is that we have to these patients to be kept on long term follow up, which is like intensive in the initial part, like 3 monthly for the initial 2 years, and over the time we decrease the frequency of follow up. And secondly, the if the patient now, as already told, that lot of patients are coming with young age with these cancers. So in certain cancer, for young patient, we may consider the fertility sparing surgeries.
Yeah. So, Dr. Anju, that was the next question I was going to ask, and you precisely brought about that. So, is fertility preservation possible in ovarian cancer, or do we lose fertility in all the patients?
So yes, for like germ cell tumors, there are variety of tumors like epithelial ovarian cancers and germ cell tumors. So usually the young patients present with the germ cell tumors are more common in young patient, and because in these patients we can go for the fertility preserving surgery, which usually include the unilateral salpingo-oophorectomy. And whenever there is a doubt about the diagnosis, intraoperatively we can send the frozen section and can decide upon the further management to avoid these the more extensive surgery, as these patients are very apprehensive about their fertility, and all the family members, like it is like a shock to them, it takes time to accept this. So we must address these fertility issues also, they may vary from while managing these patients.
Shamsa, even with the better supportive care medication available today, so because of which chemotherapy has been become much easier than what it was before. And you might have also, we have all experienced that a lot of our patients are going to work except the day for the chemotherapy. Still most of the patients are scared of taking chemotherapy. So, my first question is, do all the patients with ovarian cancer need chemotherapy? And my second question is, are there any newer modalities of treatment which are available apart from chemotherapy?
Right. So, so chemotherapy has evolved quite a bit over the last 2 to 3 decades. So if you were to name a few drugs, we were using drugs like cyclophosphamide and platinum, in late 80s, I guess. But currently, the drugs which are available are paclitaxel and platinum, particularly carboplatinum. And let me tell the listeners that these are extremely well tolerated drugs by and large, especially for women who come to us in a reasonably good health and walking. And the only problem with the chemotherapy drug, which we face mainly for women, is hair loss, because there is very little chance that hair loss will not happen. So that, of course, is disturbing for a lot of women. But then life comes first. I mean, this is what I tell my patients. So hair loss is kind of temporary and will come back once the chemotherapy has been completed. So that is number one. Number two, if somebody is sick and has a relatively, poor performance status, we also resort to not 3 weekly protocols, but weekly paclitaxel and carboplatinum. And I think the tolerance to that protocol is extremely, extremely good, and the people respond, extremely well to chemotherapy protocols. So, we see patients coming with ascites in stage 3 and stage 4, and 80% of the women or even more have a response in 2 to 3 months. So this is a very, very chemo-sensitive cancer. And when we are talking of epithelial cancer, and since you have put a very general question, if this is a patient at early age, as the previous speaker was saying, when patients have germ cell tumors, so they are even more chemosensitive and the cure rates are very, very high. So, response rates in ovarian cancers are very, very good as regards chemotherapy. And of course, the drugs are different for germ cell tumors in the young age and for epithelial cancers in the advanced stages. Now, coming to the question of do all patients require cancer chemotherapy? So, I think patients who have stage 1A disease, when it is only confined to the ovary and there is no breach of cancer into the ovarian surface, those patients can be spared from adjuvant chemotherapy, and surgery would be the mainstay of treatment. But patients who have both the ovaries involved, or who have a breach of cancer in the capsule, or who have high grade cancers on histopathology, so they do require adjuvant chemotherapy, as we call it, which is given to prevent the recurrence of cancers. So as we've been saying, that most of the patients are detected in advanced stage, therefore as was being said, in very advanced stages where surgery is not feasible, we give them 3 cycles of chemo followed by operation and another 3 cycles of chemo. But for patients who are operable, one can do the surgery first and then follow it up with the adjuvant 6 cycles of chemotherapy. Now, the final question which I can address is the use of newer modalities. So, as I said in the beginning, the role of these new agents, which are called PARP inhibitors, which are in the form of tablets, are available now, although very, very expensive. But in order for us to give these drugs to these patients, there is a clear role for testing for BRCA1 and BRCA2. And now there is a new entity called HRD, which people are testing today for patients who are in stage 2 and beyond ovarian cancer of epithelial origin. So stage 2 is when the disease is involving both the ovaries. Stage 3 is when the disease is confined to the pelvis. And stage 4 is when the disease has gone beyond the pelvis into the other parts of the body. So I'll just stop here because I think we have the MedGenome people also. But I think the issue is women must be sensitized to the availability of these BRCA1, 2, and HRD testing, irrespective of the family history being available.
So, as Dr. Shyam just mentioned about the use of something called as PARP inhibitors, which are oral tablets which would target specific genes, but they would be utilized only if the patient is carrying those genes. So, how to test for those genes? So, Dr. Suruchi, can you please enlighten about the BRCA1 and 2 testing and the HRD testing?
Yes. So, as Dr. Sham rightly mentioned that PARP inhibitors are available and overall survival associated with PARP inhibitors has been shown to be very nice, and they are associated with the mutations in BRCA1, BRCA2 or HRR genes and HRD now. So, first of all, HRR is a homologous recombination pathway by which the DNA repair mechanisms work inside the cell, and these genes that we talk like HRR genes or BRCA1, BRCA2 or these 15 HRR genes or more than that, they are associated in this pathway. I mean, they work in this pathway, and if the function of these genes are lost, then this pathway gets defective. And if this pathway gets defective, then the cells, they accumulate genomic instabilities, and this genomic instability measures the HRD, that is homologous recombination deficiency. So basically, the testing includes the mutations in BRCA1, BRCA2, which is quite popular, but it doesn't stop here. That is just the 15 to 20% of mutations that contributes to HRD in high-grade serous ovarian cancer. Rest 10% is contributed with the mutations in HRR genes other than BRCA1, BRCA2 that are involved in this repair mechanism. And there are other unknown causes or other promoter methylation which are beyond the scope of this test, which cannot be determined, that contributes around 20% of cases of high-grade ovarian cancer in which HRD testing is becoming popular. So there are almost 50% of high-grade ovarian serous cancer which are homologous recombination deficient, and those can be benefited by PARP inhibitors. So to test them, first of all is BRCA1, BRCA2, and plus if BRCA1, BRCA2 is negative, one can go for HRR testing, or one can directly go for single test which includes BRCA1, BRCA2 and HRR gene testing. And then if that comes out to be negative, then HRD testing is recommended. If BRCA1 and BRCA2 comes out to be positive, so as per testing algorithm which is evolving, the test should be done on tumor block. If the biopsy block is available, then the test should be done on tumor block, because tumor block will represent both somatic cells as well as germline cells. So if BRCA1, BRCA2 comes out to be positive on tumor block at relatively high burden, then it is suspected to be a germline test. In that case, a Sanger test on blood is recommended to determine whether it is of germline origin. If the patient is presented with the BRCA1 variant or BRCA2 variant in the germline origin, then additional family member testing is recommended in those cases, so as to assess the risk in family members. So this should be the testing algorithm. Rather than going on for directly hereditary cancer testing on blood, tumor block should be tested for BRCA and HRR genes, and HRD test can also be performed on tumor block. If BRCA1, BRCA2 comes out to be negative, then HRR gene testing and HRD gene testing should be followed. If there is a strong family history and BRCA1, BRCA2 or HRR gene still comes out to be negative, it is not that still there could not be any BRCA1 or any HRR gene variant that is not following up in the family, because we should not forget that 20% of cases are only genetic, rest all are somatic. So women present with 12% general risk of developing ovarian cancer. So in our experience, we have seen families with a very strong family history of cancer, but presented with the ovarian or breast cancer, but not having any BRCA1 or BRCA2 variant. Still the family history is strong, and when the family member is tested, they are having any BRCA variant. So it is vice versa. It is both way around. It is not like that if there is a strong family history, then it is the cancer presentation in that particular family member is due to BRCA mutation only. It could be isolated somatic case also.
I think I lost Dr. Suruchi, but she yes, you are there. So you very comprehensively told about BRCA1, BRCA2, and HRD testing. And what is was very important to note was that though about 50% of the female with high grade serous ovarian cancers can harbor one of these, but only 15 to 20% of those would be actually hereditary and their family would be at risk, and not everybody would have to undergo screening. Dr. Anju, um, saw the questions and comments from the listeners as well. Uh, what are the complications after the surgery for ovarian cancer?
So, because the like for the surgery, like staging laparotomy, there can be the risk of the during the procedure there can be the risk of ureteric injury and the vessel injury and bowel injury, because the sometime if it is long standing there can be adhesions, and because the patient presenting with advanced disease we might need to do there can be the tumor deposits over the bowel also and the other major organ like liver and spleen. So the patient should be explained before pre-operatively, while well-informed consent is very important, and we should explain the risk of bowel injuries and ureteric and vessel injury to these patients, and the risk of blood loss also, and the patient might need to undergo colostomy or ileostomy, and the formation of the permanent stoma after the surgery. And the post operatively there can be, because the most of the cancer patients are presenting in the advanced age old age patients, so pulmonary complications can be there, the risk of chest infection, and one important thing, the risk of the thromboembolism is relatively higher in these patients. So we must address all these issues while managing these patients. So post-operative period is very important, and we must encourage early embolization, chest physiotherapy to have a optimum outcome after the surgery. And if needed, because if the healing and the recovery is good, and patient needs adjuvant therapy, they can go for it on a timely manner.
One of the questions which has been asked is, do you get hot and cold flushes after ovarian cancer treatment? So I expect that if the surgery requires the removal of uterus, then we will be artificially inducing a menopausal
Yes,
um,
yes, surgical
phase.
menopause and all the risk associated with it, risk of osteoporosis and other local symptoms. And these patients get it has been well documented in literature that the patient who have this surgical menopause, they are at more risk of menopausal symptom, and which is relatively earlier, even the 1 to 2 year after surgery. So, which includes local symptoms like hot flushes, vulvovaginal symptoms, and long-term risk of osteoporosis and cardiovascular complication. So these issues must be addressed.
But with time, the patients do tend to adapt to the changes in the hormonal level, and we do have certain medications available to help them tide over that period.
Yeah, yeah, yeah. Yes.
Uh, Shyam sir, if the patient is diagnosed in stage 4, as you mentioned, the disease being outside the pelvis and the lung or inside the liver, uh, is that the end of the road, or still we can prolong their life with uh, chemotherapy?
Right. So I think we've made a lot of progress in trying to convert ovarian cancer, especially the epithelial one, which occurs in middle-aged and elderly women, into a chronic disease. So what I mean to say by that is, so to just you know address your question verbatim, it is actually not the end of the road. It is the beginning of a journey in a patient who is diagnosed in advanced stage of ovarian cancer. If it is stage 3 cancer, for example, when there is only ascites and it is only affecting the omentum and the peritoneum, a cure is also possible. Permanent cure is also possible. So it is not that all the patients, when they come to us with ascites and peritoneal involvement, will not be cured. So I think nearly 40% patients will relapse after their definitive treatment in the form of an operation and 6 cycles of chemotherapy. And as I said, if these patients have HRD or BRCA1/2 abnormality, then we are also using PARP inhibitors like olaparib to increase their cure rates and even survival. But when it comes to a relapse setting, when the patient has taken definitive therapy and 1 year or 2 years down the line, when we are following them up with CA125 levels, which are being done repeatedly at periodic intervals, and an ultrasound or a CT scan. So, there are two kinds of patients when they relapse. One is there is a gap of more than 1 year or 2 years, and the relapse has happened at only one point in the body, in the pelvis or in the abdomen. So, this patient can again be cured by doing a surgery and subsequent chemotherapy. But yes, if the patient has a disseminated disease in the abdomen, well, then a repeat surgery is usually not possible. And we have several drugs to be used in a sequential fashion to keep the disease in control for long periods of time. And these patients can go on to live for 3, 4, 5, or even more years with the availability of these newer agents, which are targeted drugs. For example, the angiogenesis inhibitors like bevacizumab, like liposomal doxorubicin, like gemcitabine, and the use of these drugs like olaparib and rucaparib. So I think we really need to judiciously use these agents in a sequential fashion, and it is not the end of the road, and really needs to consult the proper medical oncologists at a center where all the facilities for surgery and chemotherapy and even radiation could have a role. I mean, we have patients who have had localized disease, which was perhaps not operable, and we also used radiation therapy, for that local area. But yes, chemotherapy is the mainstay of treatment for patients who have, stage 4 or relapse of ovarian cancer. So just another thing I like to add here, that patients, the CA125 is a marker for epithelial ovarian cancer, and we do see, rising CA125 levels without any evidence of disease in the CT scan or PET scan. So those patients can be left untreated until they show symptoms or signs in the X-rays or in the CT scan or PET scan. So that is going into a little more detail into the technical part, but I think one should not get totally disheartened today when a patient is diagnosed to be having advanced ovarian cancer. So there is a lot of hope, and I have patients going on for more than 10 years with a relapse or an advanced stage of ovarian cancer.
So, Shyam sir rightly mentioned that there is a lot of hope even in the metastatic setting and the other advanced stages. And now we can keep the disease under control and give them a very good quality of life for 3 to 5 years, even after being diagnosed in such late stages. One of the questions that I find in the comment box is, can young girls below puberty also get ovarian cancer? So here I would like to answer stating that ovarian cancer is of various different type of histology. It is not just one type of cancer, it is different type of cancer. You might have heard all of us using something like high grade serous histology, that is the epithelial ovarian cancer. There are other ovarian cancers like germ cell tumors, like sex cord stromal tumors. So epithelial ovarian cancer does not happen in that age group. Germ cell tumors and sex-cord stromal tumors can happen, though they are also more common post puberty, but they can still happen in the teenage group. Most importantly, both of these are extremely curable cancers with a cure rate more than 90%. So, uh, even if they are diagnosed, it's just like having some other disease which would require treatment, but the patient will have a normal life expectancy.
Dr.
Uh,
Nidhi, I would like to add one more thing that, the girls with dysgenetic gonads, they are at more risk of the germ cell tumor like dysgerminoma, and we are getting such patients who are often missed in the periphery with these dysgenetic gonads. So, while evaluating, even at the peripheral center, we must, even a young girl presenting with abdominal lump or pain abdomen, we must not ignore this and do the further evaluations, because they have very good prognosis if managed on time. So
right.
this is one more thing while managing these females.
Right. And as Dr. Anju mentioned, one other modality is one other type of ovarian tumor is something called as borderline ovarian cancers, which may present as a very huge ovarian mass, but just doing an optimal surgery cures these patients, and these patients do not require any further treatment in form of chemotherapy or radiation therapy or any targeted therapy for that matter. Uh, I
Can I
am
make a
looking.
point,
I'm
Dr.
from
Nidhi?
Yes, sir. Yes, sir.
Right. So I think I want to just make this important point regarding the role of surgery in patients with ovarian cancer. So, I think in the society, in the nursing homes, etc. So whenever they see an ovarian mass or an ovarian tumor, so people tend to subject them to surgery. So actually, the point is that if somebody has an ovarian cancer, a radical surgery is the key to success. So I think that point needs to be driven home amongst the gynecologists and even the people at large, that unless you perform a radical surgery, which is to be done by experienced gynae oncology surgeons, in order to remove not only the uterus, ovaries, omentum, and you really need to diligently look inside the abdomen from below the diaphragm and so on. So unless the operation is done in a perfect fashion, you will never get the desired effect. So I think one clear message to people there is that if somebody is suspected to be having diagnosed with ovarian cancer, you must go and look out for a center where the surgical expertise is available, so that appropriate radical surgery can be performed, which I think is not possible to be done by ordinary or who is not experienced for doing the gynae oncology surgery. So I think that is a point I want to drive home regarding the surgery.
Yes, that is a very important point that Shamsa made. Not only a surgeon who is not experienced in doing ovarian cancer surgery would miss looking at regions which may not be have picked up any lesion on the CT scan, but actually needs to be taken care of while the surgeon is performing the operation. But also because a person who is not experienced in this kind of surgery may upstage the early stage tumors, for example doing a procedure laparoscopically and spilling the contents, uh, uh, instead of performing an open laparotomy. So we had a very good discussion with the help of Shyam sir, Dr. Niti, Dr. Suruchi, and Dr. Anju. And I think we have been able to answer most of the common queries people do have as regards to ovarian cancer. Now,
Ma'am, from genomics point of view, I just want to add one point
please do.
that if family if some member in the family has been detected with a familial variant in HRR or BRCA1 BRCA2 gene, so additional family member testing is recommended for various reasons. First, for the risk assessment of other family members developing a cancer. Then there would be some women at reproductive age in that family, so they can take reproductive decisions in terms of pre-implantation genetic testing if they want to do on their embryos, or they want to take up some other reproductive options other than like if they are tested positive, other than the conventional method of reproduction. So these points I mean directs that additional family member testing is important whenever a positive BRCA member is found in the family.
That's a very important point, Dr. Suruchi. Dr. Anju, do you have any take home messages for the listeners?
Yes, I just want to reinforce that whenever any female presenting with, especially the old age female and postmenopausal female with vague symptoms like early satiety and all, we should good history taking is very important to point towards some of the risk factor, and we should at least do a transvaginal ultrasound to pick up any adnexal mass or if endometrial is thickened, and for the female as a well woman clinic, we should do a screening by mammography and pap smear also. We should just to prevent the other cancers also, and on detect at the early stage.
So, we all thank you, Dr. Anju, and we all had a very good discussion. And the points that uh, the esteemed panelist highlighted were that unfortunately, ovarian cancer is diagnosed at an advanced stage because of very non-specific symptomatology. Having said that, even in advanced stage, the patients can be cured, and even in metastatic stage, their lives can be prolonged with newer modalities of treatment available. Uh, there are about 15 to 20% ovarian cancers who harbor mutations that are transmitted by familial nature. And apart from these, there are other 30% patients who can be offered newer treatment like PARP inhibitors, which are targeted against those mutations. Um, but most importantly, what we all wanted to convey is that the treatment is very specialized, and it should be done at a center which is dedicated for cancer treatment, has a facility for tumor board discussion among the surgical, medical, radiation oncologist, radiologist, pathologist, and geneticist, uh, which would really give us a good quality of life and a long overall survival. From here, I would like to hand over to Dr. Asawari. Thank you very much.
Thank you everyone for taking out your valuable time. Further to this, we also have an interesting session with Dr. Priya Ganesh Kumar from Foxy, and she would be sharing her views now.
We have Dr. Priya Ganesh Kumar with us, and she is the chairperson of Gynaecological Oncology Committee, Foxy, and medical director, 𝐸𝐈𝐌𝐈 Healthcare. Hello, ma'am. So my question To you, the first question to you is, what red flags suggest you towards ovarian malignancy and no other gynecological condition in your clinical practice? What would be the differentiating signs of the same as in your experience?
Actually, ovarian cancer unfortunately doesn't have a very high red flags. It is on understanding and a suspicion that we actually can identify, or identify this thing, early cancer or ovarian cancer, because it doesn't have any particular sign and symptoms. Say it can be any weight reduction, okay, or a reduction in weight, or there might be a sudden increase in weight, or most probably also, like if you have constipation, non-specific symptoms, bloating of the abdomen, constipation, tiredness, and might be leg edema, might be sleep disturbances, all these things, these are very generalized symptoms which don't point out towards ovarian cancer, but we should have all these things in our mind, that we have to evaluate such a lady and try to find out. And the another thing which is a very important red flag, which actually rings the alarm to us, is her family history. So we all have to be very categorically, we all have to ask the family history, which is very important. Moreover, if we have done we do understand that hereditary breast and ovarian cancer syndromes play a lot of role in identifying the patients, and moreover we can also keep them under surveillance. So and having a family history background of mother, or sisters having ovarian cancer or colon cancer, rectal colorectal cancer, or even for that matter breast cancer, we should be very much aware, and we should then be trying to look out into, we have to actually identify them, we have to look into and get these things, like by doing say sonography and understanding her ovaries. So then that's how you will identify.
Thank you so much for answering that, ma'am. Okay, so our next question to you is so the next question is, can ovarian cancer be prevented? If so, how?
Ovarian cancer, most of them being the hereditary, like 10% of the ovarian cancers are hereditary in nature. It can be prevented, if I can't say prevented, but can be identified at a very early stage if we are again aware of it. And to make the things more clearer, the ovarian cancer rates have actually increased now. And in Asia, India is topping after China in the rates of ovarian cancers. So when you see the cancer rates and Globacon 2018 rates, they've also all shown a rise. So what we do when we have to prevent it, first of all, as I told you in my earlier talk also, that if there is a BRCA aberrancy, or there is a mutation in these genes, like BRCA1 and 2, MLH1, MLH and MSH, these are all mutations which has occurred in these protective genes. If these factors are there, if there is a strong family history, then we will be definitely putting, first of all, if there is a family history, we will be going for genetic examination. That is going without say. You have to do a genetic mapping. We have to understand whether there is any mutation in these genes. And if you to go further, if there is a mutation in BRCA1 genes, say 35 to 70% of the ladies having BRCA1 genes can have the propensity of developing an ovarian cancer. So definitely we have to understand these genetics predispositions. We have to understand, we have to identify the mutations, genetic mutations. And if so, then these women, because they have the high propensity of developing into an ovarian cancer, we have to keep them under surveillance, doing their annual screening by sonography. And we do have also CA125 and other tumor markers also, which are more specific. And if you're going to do them, then these people can be identified. And nowadays we are also seeing a lot of PCOD cases have increased. Also in our practice, we are also seeing that infertility rates have increased. So many gonadotropics are being given for the infertility. But these are all the risk. I mean, one type of risk factor. Early menarche, late menopause, obesity. And also you would have seen the trend of lactation has reduced. So if we have to again, what are we? We are into a very risk population now with the trend which is going on. So we better be more prepared. Okay, now giving an good OC pills or fertility prevention, this family planning medication sometimes have seen that we have reduced the ovulation, monthly ovulation, thereby sometimes. So these are very minor things, but definitely they have proved their benefit over ovarian cancers.
Okay, ma'am. Yeah. So my next question to you is, any initiatives from 𝐕𝐾𝐲 for ovarian cancer that you are involved in? Please share those.
So through 𝐕𝐾𝐲, we have been always trying to create awareness, educate our 𝐕𝐾𝐲ians, and having a lot of webinars. Nowadays, webinars have really increased. So time and again, we have focused webinars on focused tumors. So recently, in the month of I think October, we had a focused conference on ovarian tumor through my committee of 𝐕𝐾𝐲, and simultaneously, these type of webinars will actually create an awareness and understanding amongst 𝐕𝐾𝐲ians. We have been doing a lot of cervical cancer elimination activities which are going on through my committee. Simultaneously, in every conference of 𝐕𝐾𝐲, there is a space, workshop for oncology, gynae oncology, whereby these topics are taken up in a more specific and focused manner, inviting the world-class speakers and KOLs to share their experiences. So there is definitely an awareness which has increased. The 𝐕𝐾𝐲ians are understanding now the awareness. Since they have increased, the identification of the early diseases have also increased, and that's how we are in a position to now understand it better. Rather, do not do any under treatment. Whenever there is a sign of doubt comes up, involving the other specialists like gynae oncologists to come up onto the picture, rather than doing your own treatment sort of thing. So because the awareness has increased, there is a lot of involvement of gynae oncology now into the practice, along with the 𝐕𝐾𝐲ians, along with the normal grassroots level gynecologists who are treating the patient, and the rates of references have also increased. So this is all what we are doing from our 𝐕𝐾𝐲 to get the awareness drive.
Thank you so much for sharing all the amazing work that you are doing with 𝐕𝐾𝐲, ma'am. So finally, what would your words of advice would be to everyone regarding ovarian cancer?
My word of advice is, first of all, open up your think tank. That's very important. Open up the horizon, widen up your horizon of identifying. I mean, it's like, once you know it, you start identifying it. But if you do not know it, then you will not. It will just pass away. So we have to be more categorically suspicious about all these factors. Take a very good history. Family history is very, very important. Suspicion on symptoms which are not regular, like might be sudden weight loss or sudden bloating of the abdomen. No, just don't put it up like gastric distension or something of that sort. And again, have an understanding on late menopause. This is very important. So whenever a lady has a late menopause, try to do her complete evaluation, ovarian evaluation, cervical, endometrial evaluation, because these are all the things which are related. Cervix at least is only for cervical cancer. cancers and HPV related. But when you have to talk about an late menopause, think about all this. And another thing, when we are doing this infertility treatment, give a break. That's very important, that we cannot keep on giving her an ovulation induction medication that leads further to all these detrimental factors. And again, my request to all my Foxians and on this Ovarian Tumor Day, Awareness Day, would be that have an understanding that ovarian cancers are on rise, and they come to us only in the late stage whenever there is a cyst, a complex cyst. And then the IHC tumor markers have now very nicely, it has come up for ovarian cancer is one cancer where we can understand by putting up those ovarian tumor markers. If you're not understanding it, at least refer it to a specialist rather than doing your own treatment, which might be a suboptimal treatment for this lady. And yes, when you identify such type of suspicious one, please involve the specialist, gynae-oncologist. We have medical people with us, so we have so many specialists now. We are not in any small area where we cannot avail of the specialist services. So definitely involving people, putting it up in a tumor board in a higher center which has a tumor board, and doing an optimal therapy for her would be the best that we can do for a patient.
Thank you so much, ma'am. Thank you for sharing all your thoughts, and thank you for taking out time. Thank you so much.
Thank you.